All right, so our topics today are tissue integrity. So we're going to talk about the assessment of our tissues, our care for our tissues to keep them, intact. And then we also have to throw in some pre and post-op nursing care because it's not anywhere else in this course, and it just made the most sense to put it with this. So, all right. Our objectives today, we are going to differentiate normal versus abnormal assessment findings related to tissue integrity. We're going to describe measures to maintain and improve our client's tissue integrity. We're going to identify factors that may impact tissue integrity across the lifespan. We're going to develop a teaching plan to support optimal tissue integrity. And then again, we're going to discuss common pre and post-op nursing care things. So when we talk about our integumentary system, just like with our other body systems, we are going to talk a little bit about the anatomy and physiology. Not everything, because as I've told my class multiple times, I am not an anatomy professor, and you don't want me to be. But I'm going to tell you a little bit. So obviously, your integumentary system is your skin. It's the biggest organ in the body, covers you from head to toe. It also includes things like your nails, your hair, your sebaceous glands, which are your oil glands, and then your sweat glands. So it kind of includes all of those things. Again, the basic structures of the integumentary system are going to be your skin, your hair, your nails, those exocrine glands, so the sweat and oil, and then the sensory nerves. There are multiple layers of the skin. So your epidermis, that outermost layer. You've got your dermis, which is in the middle, and then you've got your hypodermis. Also, a lot of times you'll hear it called the subcutaneous layer. That's where most of your fat is sitting, is in that subcutaneous layer. It's important to know these different layers for multiple reasons. One is when we talk about pressure injuries, we stage them based on how deep they go through the tissues. So that's one reason to know it. Another reason is the deeper, the longer it's going to take it to. You're fine. Yeah, some of them like this. I mean, they're over there. They can come over here. But yeah, so if you have a deeper wound, like a surgical wound that goes through all layers, because obviously we've cut into a body, that is going to heal much slower than something that's just there on the surface, like road rash or a rug burn or something. So it's important to know what those layers look like and how deep they are. So again, 3 layers: epidermis, dermis, and hypodermis. Epidermis is the outermost layer. Its point of being is to provide a protective covering against infection and water loss. So if you have a break in your skin, you can get an infection, right? If you have large breaks in skin, you can become hypovolemic because you lose a lot of water through that open skin. So like our burn patients lose a lot of water because they don't have that outermost layer of skin anymore. That dermis, the second layer, is thicker. This is where capillaries, blood vessels, your lymph vessels, they all come into this area. Your hair follicles and glands, like the sweat glands, they come down into that area and then go out to the skin level. Your hypodermis, like I said earlier, it's also called the subcutaneous layer because that's where your fat is. It is almost entirely fat tissue. And starting now, you need to start thinking about the fact that we call fat adipose as nurses. So you're not just going to hear it called fat, it's going to be adipose tissue. And then also the adipose, the point of our adipose is that it insulates our body, so it helps regulate our temperature, but also it provides cushion to our internal organs. So if you have no body fat, you don't have any cushion to protect you. So those are what they're good for. And then they also contain blood vessels and nerves that help with that thermoregulation and sensation. Normal versus abnormal tissue findings. So a normal or expected finding would be smooth, intact skin, appropriate color for ethnicity, capillary refill of less than 3 seconds or right at 3 seconds, warm, moist skin. So by moist, I don't mean wet. I mean like probably how all your skin is right now, where it's not dry, it's not flaky, it's just nice and moist. We don't want to see any edema, no erythema or redness, no injuries. We don't want to see any open wounds, bruises, things like that. An abnormal finding would be the opposite. of all of those things. So it would be an uneven or non-intact skin. It would be hyperpigmentation or a lack of color. So some of my students yesterday, we had a patient who she had something called hemosiderin staining on her legs. That's abnormal. It's indicating that there's some issues with her blood flow in her legs. So that would be an abnormal finding. Capillary refill that's slow. So if it's slower than 3 seconds, that's going to be an abnormal finding. Dry, like excessively dry, flaky dry skin, or skin that is cool or cold, because that indicates there's no blood flow to the area if it's cold. And I don't mean cold like I went outside and my hands are cold. I mean like feels like meat you took out of the refrigerator, which I know sounds gross, but that's what it feels like. It feels cold. It feels like there's nothing warm to it at all. And then obviously if we see any edema, erythema, wounds, rashes, anything like that, that's an abnormal finding. So really, if it's not normal, it's abnormal. So our nursing measures to maintain or improve our skin integrity, a frequent skin assessment. When I say frequent, how often do you guys think that is?
Every 2 hours.
How many hours?
2 hours. Twice a day?
Once a shift. Once a shift, or as often as you do an assessment. So if you're in the ICU and you're doing a head to toe every 2 or 3 hours, you would do it every 2 or 3 hours. But otherwise, it's at least once a shift, because when you're working, you want to have visualized all of their skin at least once during your shift. That way, you know what's going on. You can't recognize something that has changed if you don't have a baseline assessment of what your patient looked like in the first place. So at least once a shift, you want to get a good look at everything. Another way to maintain or improve that integrity is to reposition them regularly. And that's when we want that 2 hours. You want to reposition them around every 2 hours if they can't do it themselves. It only takes 2 hours to develop a pressure injury. So if you have someone laying directly on their butt, within 2 hours, they can have a bed sore on their tailbone, on their ischium, on their heels. So at least every 2 hours. Sometimes they may do more often. Sometimes they may say they can't be in this position at all. Like I often have clients that I say no back time at all. So they have to be on their left or their right. They can't be on their back at all because they have a significant wound already. So just pay attention to your orders, but definitely reposition them at least every 2 hours, and document it, because if it didn't get documented, it didn't happen. You want to use pressure relieving devices. What are some pressure relieving devices that you guys can think of?
Pillows.
Pillows, yep. What? Yes, the foam dressing, so Mepilex or Mepitel or whatever brand your facility carries. Another cheap, easy one is a waffle mattress. Most hospitals have them in the clean utility. They cost about $20. You just pump it up just like it's, an inflatable to go in your pool. Those are great. They also make waffle cushions to put in the chair. So if they're going to get up to the chair, you can get that waffle cushion and put under their bottom. But definitely all those things. They also have waffle boots too for their heels. So if they can't move their legs, you can get those waffle boots, float their heels off the bed. And then pillows are good. Wedges are better if your facility has wedges, because they do a better job of staying under the patient to offload them. But pillows are better than nothing at all. So always use something to kind of shift them left or right when you turn them. You want to maintain their hydration and nutrition. So you can't have good, healthy organs in general if you're dehydrated or malnourished. So just make sure they're getting a good, balanced diet, getting sufficient fluids so that they stay hydrated like they should. If they actually have a wound, do your dressing changes as they're ordered. Don't let the wound care nurse come in and the same dressing's been on for 3 days that should have been changed twice a day. Do those dressing changes as they're ordered. Use any appropriate topical treatments. So maybe they don't have a pressure injury, but maybe they're incontinent. If you have available to you zinc paste, any kind of barrier paste, use that to prevent that skin from opening up and breaking down. And most of those are nursing indicators. Like if you have a topical that's in your clean utility, you can grab whatever you want and put it on your client without needing an order for it. And then always monitor for signs of infection. So if you went in your client's room and their leg is red from the toes up to the knee, would you be concerned? Right, and it's hot, looks kind of swollen. So if you see things that look like they could possibly be infected, just tell the doctor. Call whoever the provider is, call them and just say, hey, I have concern because this leg or this arm or this butt or whatever looks like it might be infected. So we've got several slides like this because I try to do one for all the different times of life we have here. So for infants, there are some factors that affect how their skin integrity is, how it's maintained. They have immature skin, and by immature skin, I mean that their skin is constantly still growing and changing, and it's much more sensitive than ours as adults. So babies, they very easily get skin tears, they very easily get pressure injuries. The simplest topicals can really like soak into their skin more because they just don't have as much of a barrier as we do. So they just have very immature skin that isn't providing them as much protection as ours is. Again, prolonged duration of pressure for them can be prolonged in a shorter amount of time. So like I said, for adults, you can develop a pressure injury within 2 hours. With babies, sometimes it can be as short as 15 to 20 minutes with something under them, something on them, being in a certain position. So you really want to check their skin often. They can become over moisturized or macerated. Do you guys know what macerated means, or maceration? It's okay to say no. So maceration is, if you've ever, say you skinned your knee as a kid and mom put a Band-Aid on it and it gets all wet and moist. You know how the edges of the open area turn all white and kind of gooey? Those edges are macerated. They're overly hydrated, and so the skin is almost translucent to the point where it's all wet. Your butt can get like that if you have too much incontinence and too much moisture on it. The skin will start to become white and start to break down and just slough off because it's so wet that basically the cells are dissolving and it's falling apart. So obviously babies are incontinent because they're babies, so they're going to have issues with maceration because it's up to us to get that moisture off their skin. And then babies have poor perfusion for the same reason that their skin is immature. Their bodies are immature. Their bodies are still learning how to function outside the womb, and so they have poor perfusion to their extremities. That's why sometimes you'll see babies, their little hands and feet are blue because they're just not getting good blood flow to them and they get cold easier. So they have poor perfusion, so you really want to watch those extremities to make sure they're staying warm and getting blood flow. Some common skin problems with them, like I'd already said, but that would be diaper rash, skin tears, pressure injuries. You just really want to handle babies very gently and carefully to make sure you're not injuring them. For older adults, we're on the opposite end of the spectrum. Their skin is not mature, but now it's getting old and it's becoming frail. So it's kind of de-evolving in the opposite direction. So I'm sure all of you have had older relatives or cared for older people. They have very thin skin. Sometimes you can almost see through it. It tends very easily. You can kind of pull it up, almost see through it. They have decreased elasticity. They have less subcutaneous fat. They have a decreased blood supply because, again, everything just kind of functions worse as we get older. And then older people typically are not as well hydrated. As many of you saw yesterday, I'm sure, when you went to the facilities, it's very hard to get older people to drink an adequate amount of fluid. They lose the drive for thirst, and so they don't want to drink because they're not thirsty. And then sometimes their sense of taste change. So then what you are offering them to drink tastes gross to them, so then they don't want to drink it. So they are oftentimes dehydrated. Just like with our babies, our common skin problems are going to be skin tears and pressure injuries, but they can also get very itchy, dry, flaky skin because if it's not getting good blood flow, it'll dry out and then they're itchy and then they scratch. They can also get skin infections because, again, they're not having a good protective covering because their skin is not healthy like ours. And then they can also get something called cellulitis. Do you guys know what cellulitis is? What is it? Bacterial skin infection? Yeah. And that's like that red leg I was talking about. So like if they get an infection somewhere in their skin, it'll get red and hot and it will spread from the source of where the infection was. So got another baby on here. I had to find a baby with spina bifida because that was the first thing that came to mind when I thought of decreased mobility across a lifespan. So clients with decreased mobility could be from a stroke. It could be from spina bifida. It could be from paralysis for some other reason, but decreased mobility just means that they can't get up and move themselves as they normally would. Whatever would be normal for their age, they're not moving that way. Contributing factors could be reduced blood circulation and sensation. So maybe they're not paralyzed, but maybe they've injured that leg, and so now it's kind of numb and it's hard to get up and walk on it. when you have decreased mobility, you oftentimes have alterations in thermoregulation, meaning that they can't keep themselves warm or cold as normal. They may become incontinent. If you can't get yourself out of bed, even if you physically know you have to go to the bathroom, if you can't get yourself up to the toilet yourself, you will be functionally incontinent because you can't get up and get yourself where you need to be. And then as you are immobile in bed, you will start to lose collagen, you will start to lose muscle mass because you're not using those body parts to move yourself anymore. Skin problems we see with these types of clients are going to be skin tears and pressure injuries. Again, that's kind of universal across everyone. Again, more skin infections. And then in older patients, we don't call it diaper rash anymore. We call it incontinence associated dermatitis. It's kind of more of a dignity thing. You don't want to tell an adult of any age that you're putting a diaper on them. So that's why it's incontinence associated dermatitis, because it means the same thing. They have dermatitis of the skin based off of the incontinent stool or urine that's in contact with their skin. Another factor that can affect your skin integrity is obesity. This actually, I didn't put these legs on here because this individual is obese. I put it on here because he is actually having issues with lymphatic flow, which we have listed on here, and I'll talk about that when I get to that one. But when you have a client that is obese, they can have moisture changes. So they can either have extremely dry skin because they don't have adequate blood flow to their extremities, to their skin, or they can have increased moisture like in their body folds. So they kind of have moisture changes in both ways. They can have maceration not just on their bottom from incontinence, they can have maceration under the breast, under the abdominal pannus, under their bottom, like under where their butt kind of meets the top of their leg, because it's a skin fold now that wasn't there before. So with them, they can have that maceration anywhere in any skin fold because the moisture just sits there and can't get out. And then they have elevated skin temperature just because there's excess body weight that's causing more temperature. And then, like I said, they can have decreased blood or lymphatic flow. So oftentimes obese patients will have these swollen legs like this, and it's because there's so much weight that the lymph vessels can no longer return that lymph back up to the upper half of their body, and it gets trapped in their legs. And then more and more gets sent down from the top half of their body, and their legs just get more and more swollen. And it's not body weight at this point, it's lymph fluid that's just collecting in the legs. Again, just like with everyone else, skin tears and pressure injuries are one of the most common issues, but they can also get diabetic ulcers. They can get moisture lesions in those body folds. They can just get rashes or infections in their folds. You'll oftentimes have yeast or bacterial infections in their folds that we have to treat with ointments or powders. Cancer. Cancer itself can affect your skin. Cancer treatments will 100% affect your skin. All cancer treatments are basically poison that's microdosed to kill the cancer and not kill you, but it's still going to affect all the other tissues in your body because you're taking this poison to treat it. And so our biggest skin issues we see are radiation injuries. Radiation is what cooks your food in the microwave. So when you're receiving or your patient is receiving radiation, they're basically being cooked. They're cooking the cancer to kill it, but you're getting cooked on the way through. I know that sounds terrible, but that's literally what it is. So you will see, depending on where their cancer is. So my father had anal cancer over the summer. He had radiation, inflammation, and skin damage right around his anus and in his perineum because that's where they were pointing the radiation. If they have breast cancer, it's going to be the chest and the back. If they have lung cancer, same thing. It might be from the back because that's how they're shooting the radiation in. So when you have someone receiving radiation, it's important for you as the nurse to know where they're directing that radiation so you know where to look for those injuries. Again, they may have that skin surface damage. It'll look like a burn. It'll look like they burned themselves like on the stove or something. And then as they're radiating the area until it has time to heal, there will be decreased blood supply to that area because you basically cauterized off all of the blood tissue or all the blood vessels going to that tissue. That will eventually regenerate and go away, but while they're actively receiving that radiation, it's pretty horrific. Other skin problems you might see is pressure injuries every time, guys. So just remember, any skin alteration is going to cause pressure injuries. If they're receiving radiation or chemo or both, they're going to have delayed wound healing because both of them affect your ability to heal while they're happening. They may get skin infections or cellulitis because they now have a break in their skin that we've caused, but then they can get infection. And then, like I said, they'll have that radiation-induced dermatitis. Chronic illnesses, I couldn't list them all on here, but if your client has any chronic illness, anything, COPD, kidney issues, heart issues, whatever, any chronic illness will affect their skin because when your body is combating something that's chronically causing them issues, it just can't heal like it's supposed to. It shunts all the blood supply to that area that's not working properly. But on here, the common ones you're going to see is if they have any hepatic or liver issues, any kidney issues, or any cardiovascular issues. Those have some pretty common significant skin issues that you'll start to recognize as you work more as nurses. So those are, you'll see skin changes from those. So like if somebody had liver issues, what's something you can think that you would see in their skin that's different? Yeah, they can become jaundice. They can also become very itchy. Their skin will get very dry and itchy, and it's just related to the liver failure. Your kidney patients will sometimes get what they call uremic frost on their skin, and it's basically the urea in their body is not getting processed out by their kidneys properly, and it comes through their skin, and it literally looks like frost, and it itches like crazy when they have that. You'll see that often. Cardiovascular diseases, you're going to see a lot of issues with poor perfusion. So they may have blue fingers, blue toes, cold hands, cold feet, things like that. They may have more issues with wounds becoming necrotic or the tissue dying because they're not getting blood flow to something because their cardiovascular system is compromised. You may also see skin changes due to chronic malnutrition. So if there's someone who just doesn't have access to adequate food, or they're choosing not to eat, like our anorexic or bulimic patients, they can start to have skin changes because they're not getting all the vitamins and minerals they need for their skin to function properly. And then also psychosocial issues. Oftentimes people with chronic depression will have skin issues because they don't have the energy or the want to get up and move around, to eat right, to clean themselves correctly. And so they'll start to have issues from that because they're just not taking care of themselves properly. Again, pressure injuries is one of our skin problems because, like I said, it's everything. You might also see skin tears, especially in your liver failure patients. Their skin is very fragile. Sometimes you can just touch them, with your hands, and you'll tear their skin off just from your thumb touching their skin. Again, they're more prone to infections. And then there may be moisture-associated lesions, on their bottom and their skin folds, things like that. So the teaching plan for optimal tissue integrity, it kind of goes over several pages because I wanted to make sure I outlined it for you guys well. Anytime you make a teaching plan, it's just like anything else with nursing, you have to have a goal. So for this one, I said we would educate the patient on practices to maintain healthy skin and to prevent skin breakdown. So we're assuming this client does not have any breakdown yet, so we're trying to maintain good, healthy skin so we don't get an extra problem. You want to do your assessment first, always. So we're going to assess the patient's current skin condition, their mobility, any risk factors they have. Those risk factors can be immobility, incontinence, poor nutrition. The list goes on. There could be many more things. But by doing this, it allows you to personalize that education. Maybe they eat well and they don't really have any chronic conditions, but they've been paralyzed in a car accident. I'm really mostly concerned about their mobility at that point and their ability to care for themselves. If it's someone else, maybe it's an older person who's not eating and drinking like they should, and they're prone to falling. I have different concerns for them. So you want to always find out what their issues are so you can personalize their education. Our topics to teach is daily skincare. You want to cleanse that skin gently with mild soap and warm water. You want to pat the skin dry, especially in those tender skin folds on their perineum, just to prevent any moisture buildup. And then you want to apply a moisturizer in areas that need it to prevent dryness. So if you have an area prone to moisture, you don't put a moisturizer there, but like elbows, arms, legs, things like that, we could put a moisturizer on just to promote that optimal level of moisture. Areas that are already too wet, you would want to put something on to help keep it dry. So you always just want to pick something based off what is already happening. I specifically said gently for our cleansing because I know I've told all of you before, but I'll say it again. Some people think they have to scrub to clean people, and then all you're doing is ripping all their skin off. So anytime you're doing any type of hygiene on someone, it's a gentle technique. And I have to remind nurses who've been working for 20 years of this, so I'm reminding you before you become that nurse. Mm-hmm. Pressure relief, like I said, reposition at least every 2 hours for those patients who can't reposition themselves. If it was one of you, you just want to remind them. So if they can move themselves, you go in every 2 hours and you say, hey, like, have you been laying on this side for a while? Why don't we switch positions? And you can let them do it themselves, but you still want to be educating them on the importance of repositioning. It can be every 15 minutes if they're up in the chair. So not lying in bed, but if they're sitting up in a chair like Miss Dykes is right now, you can ask them to kind of shift from left to right, butt cheek essentially, just to make sure they're not keeping too much weight on those ischium and on those sit bones. Like you guys said earlier, we want to use pillows, foam dressings, any kind of waffle product, waffle mattress, chair, boots, anything like that, just to help offload anywhere that would be considered a bony prominence. Hydration and nutrition, you always need to remind patients to drink enough. Even the people you think drink enough probably don't. So just always remind your clients to drink 6 to 8 glasses of water a day, and really encourage them to eat that balanced diet. So, don't focus just on carbs, even though they're the most delicious and we all love them. You need to eat more than pasta, potatoes, and bread. Make sure they're eating proteins. Make sure they're getting fruits and vegetables to get all those good vitamins to keep their skin healthy. Early warning signs to teach them to look for, or their caregivers at home to look for, is any redness, any swelling, any sores, any blisters. Believe it or not, a fluid-filled blister on a bony prominence is a stage 2 pressure injury, because if there is fluid in a blister, that means that it's gone all the way through that first layer of skin. So if you see a new blister, it's a cause for concern. They also need to know to notify their healthcare provider if their skin changes. So if they go home and their skin looks beautiful, and 2 weeks later they're now red on their tailbone and on their ischium, they need to call their doctor and let them know that something's going on. And then just avoid irritants. So minimize exposure to harsh soaps, minimize exposure to prolonged moisture. Even too much sweat can be too much moisture for someone, especially in those skin folds. So under the breast, under the belly. So just make sure they're minimizing that as much as they can by getting rid of it. Evaluation. So after you've taught them, you evaluate by asking them to explain it back to you. So you say, hey, in your own words, can you tell me what I just taught you? Can you tell me how you're going to keep your skin healthy? You want to either observe a return demonstration, meaning if I showed them how to apply a foam dressing, I want them to show me how they would apply that foam dressing to that same area. Teach back is almost always going to be our standard for evaluating if someone knows something. It's like we do with you guys. That's why you did competencies. We want you to teach us what we've taught you. If you can teach it to me, you obviously know it. So teach back is always, and that's a word you're going to hear a lot, is teach back. Teach back is the gold standard for knowing someone knows something. For follow-up, maybe we taught them on Friday because we thought they were going home on Saturday. If they're still in the hospital on Monday, follow up again. Reinforce that teaching again when you come back. It never hurts to reinforce and ask, like, do you remember? Do you remember how I said we were going to prevent pressure injuries? All right, so pressure injuries, like I said, they can happen to any patient of any age with any diagnosis. Everyone in this room is susceptible to pressure injuries, especially when you're sitting in a hard chair for 4 hours studying for an exam. Mm-hmm. These chairs do not have any cushion, and you're all at risk right now. Even you, although yours is kind of cushioned.
It's not too bad.
Not too bad. We as nurses are considered that frontline defense for preventing this complication, either through educating our patients to turn, or physically turning them, physically putting those dressings on. When they look at risk factors in the hospital and risk factors that can be fixed by staff, pressure injuries are what we consider a nurse sensitive indicator, meaning it falls on us to prevent it and to make sure it's not happening. Our next few slides are going to kind of give you guys some images and resources to help you prevent your patients from developing pressure injuries while they're in the hospital. Yes?
Why don't we get pressure injuries from like washes?
Because it's putting pressure under a device. So typically a pressure injury is going to be on a bony prominence. So elbows, scapula, ischium, any device your patient has. So watch, Foley, oxygen tubing. If it lays on them anywhere and the wound matches the shape, you can get a pressure injury from it. So that's why when I was teaching you guys how to put a Foley in and how to put the tubing, if any of you noticed, I don't like when the tubing lays on their leg because I've had patients get like a full thickness pressure injury from a Foley tubing that laid across the top of their leg. So any device on your patient's body, when you go in to do an assessment, you should be lifting and looking under it, even their IV tubing. I've had patients get IV tubing pressure injuries if they're sick enough. But yeah, that would be called a device-associated pressure injury. Good question. All right, so these come directly from the NPIAP. It's our pressure injury organization for the entire country. This one is for lightly pigmented skin. So folks who look like me, Mrs. Dykes, this is kind of what they look like. I know the pictures aren't great on here, but they look better on your computers. So a stage 1 pressure injury just means non-blanching redness. When I say non-blanching, what does that mean? Right. So if it's red and I poke it, it stays red. That indicates that there's decreased or lack of blood flow to the area. So if their butt is red and I poke on it and it stays red, that indicates that there's a pressure injury under there. Stage 1s can be reversed if you catch them early enough. So if you come in the morning and you do your assessment at 8 a.m. and their butt is red, offload them and come back in a few hours. If it goes away, you fixed it. If it's still there, now we have concern that maybe it's deeper. So anytime you find redness on a patient, reposition whatever body part it is. If it's their elbow, if it's their heel, if it's their butt, whatever. But it's got to be non-blanching redness and the skin still has to be intact. So it still needs to look like nice, smooth skin. It's just red. A stage 2 means partial thickness. That means it's through that outer layer, but not all the way through. You should not see fat. You should not see muscle. You should not see bone in these. It should just be kind of partially through. It does need to be over a bony prominence or under a device. So if you find a wound on your patient's thigh and they've never had a device there and they've never been laying against something there, that's not pressure injury because there is no source of pressure. So it needs to be some source of pressure to it. Like I said earlier, it also includes any fluid-filled blisters on bony prominences or under devices. So you're going to see blisters for other reasons. Maybe they have a cold sore on their lip. Maybe they have chickenpox. Maybe they have impetigo. Those are all fluid-filled blisters. They're not on bony prominences. If it's on elbow, butt, heels, whatever, and it's fluid-filled, and it's got to be clear fluid. We'll get to blood-filled blisters here in a minute. But clear fluid-filled blisters under a source of pressure are a stage 2 pressure injury. Stage 3 is what we call full thickness. You're going to see adipose tissue in this. If you've never seen adipose, you will. You're going to see it at some point. If you don't see it in a pressure injury, you're going to see it in a surgical injury. So you're going to see it through there. Human fat looks just like chicken fat. Again, I know it's gross, but that's what it looks like. It's yellow. It's kind of oily looking almost. If you look in a wound and you recognize that it's fat, you're now full thickness. You're going to call it a stage 3. Again, same thing like stage 2, needs to be on a bony prominence or under a device. Stage 4 is also full thickness, but at this point, we're now seeing bone and muscle. Muscle looks like steak. It's going to have like straight lines to it. You're going to be able to tell that it's muscle tissue. Bone, I think we all know what bone looks like. You can tell that it's bone. These are really the worst injuries you can have because they're all the way through. These patients are highly at risk for infection because we're all the way down to the bone. They can get infection in their bone at this point. And unstageable is going to be one that you can't see the base of it. So if it's an open wound and it's got that yellow or white kind of sluffy pus-like looking material on it, I can't see what's under that. I can't stage it if I don't know what's under there. So you would call that unstageable. Unstageable does not mean I didn't remove the dressing. I've had people say that. You take the dressing off and you look at it with your eyeballs. You cannot stage it by leaving the dressing on and saying unstageable. Unstageable can also look like a black eschar covered wound. Oftentimes you'll see these on people's heels. Eschar is really just like a big scab. But again, you can't visualize what's under that, so you can't stage it because you don't know what's under there. And then our last one is what we call a deep tissue pressure injury. These will eventually turn into a stage 3 or a stage 4. What it is you see them oftentimes on like people who have fallen at home and lied on the ground for 8 hours before someone comes to check on them. They've had prolonged exposure somewhere. Sometimes these aren't even on a bony prominence, but it's because like I fell and I laid on my right side. I may have DTIs the length of the right side of my body because I laid on that side that whole time. This does not originate at the skin level. The injury started all the way at the bone, and it has now worked its way out to the skin, which means at some point it's going to open and it's going to be a deep crater all the way down to the bone. So if you see dark purple or maroon non-blanching redness on your patient and you know they've had prolonged exposure to not moving, you need to be concerned and you need to escalate this to a physician immediately because it is going to open and it's going to be awful. So like I said, this one is our lightly skinned folks. This one is for darkly pigmented skin because it does look different. So on someone who is darker, and I'm going to use Abby because he's in my clinical group and we had this discussion yesterday. Abby is very dark. You're probably not going to have redness that I can recognize. So on someone that is dark like him, you're going to look for differences in color. So if I had concern for you and I rolled you over and looked at your bottom, I see what this skin looks like. I see what this skin looks like. If the skin on his tailbone directly is much darker, or if it feels different, if it feels kind of boggy or it feels too hot, I have concern there's a pressure injury under there because it's different. So with darker skin, you have to look at differences from what we know is good to what we're concerned about. So a stage 1 on him might just look like a very dark area right on his tailbone. A stage 2 is going to look open. So you're going to know that it's a stage 2 because it's going to look like that first layer of skin is gone and it's going to be over a bony prominence. So it's going to look very similar. Same thing with a stage 3 or a stage 4. We're going to recognize that adipose. We're going to recognize that muscle or that bone in there. Unstageable, same thing. We're going to see it's going to have slough or necrotic tissue on it. So we're going to know. The DTI is the hard one to recognize on darker skinned people. So oftentimes we will call a DTI on someone, Abby's complexion, a stage 1 because we don't know. It just looks dark. I don't know what it is. So if you have a darker skinned patient that you have concern for a pressure injury like on their tailbone or their heel, you want to reassess it more often because it will eventually open up if it's something deeper. If it's just the stage 1, it'll resolve eventually. If it's that deep tissue injury, it's going to open up. And oftentimes, unfortunately, darkly pigmented patients have more complications because of that. We don't recognize it early enough. We don't intervene early enough. And it's unfortunate and I hate it. So that's why I always make sure I cover this with you guys. We've got pressure injury and other resources on here. I'm going to go to this first link because that's not as long as the second one. But over in the United Kingdom, they actually put together this website that's, I think the title of it, when we go to it, I think it's literally titled Skin Injuries on Black and Brown Skin is what they call it. But it shows you what different injuries kind of look like on that darker complexion. Because again, it's important. It's important to know what that looks like. I just gotta wait for it to load because my computer is slow.
I pulled this website up a lot. It's an excellent
Because it's
resource.
not just pressure injuries.
Mm-hmm.
Actually, it's just called black and brown skin now. It used to be called skin injuries.
Oh, they redid it. Yeah,
They
they
did
did.
review it. I know. I noticed it the other day. Let me see. They've moved things around on me, so I've got to find. So down here at the bottom where it says conditions, you can pick different things. So we'll go with lower limb just for fun. So these are different types of rashes, different types of injuries on darker skin to kind of show you how they look different. So this first one, ichthyosis, it's kind of a thick, itchy, scaly skin condition. Same thing with lichen planus. On a lighter skinned person, it literally looks like white. It looks like lichen on a tree. If you've ever seen lichen growing on a tree or a rock, on someone like me, it looks like lichen. On darker skin, it almost looks more brown and raised. A pruritic papular eruption is just kind of like a big widespread like rash with like raised welts. Looks different on darker skin. Jock itch kind of just looks like jock itch on anyone. Skin sloughing. It's literally that first layer of skin is just sloughing off from injury or dryness. There's another one of lichen planus. Gangrene. Gangrene sometimes is hard to recognize right away because it just kind of looks like a slight discoloration until it starts to smell like rotting flesh. But you don't always recognize it. But then there's a whole bunch on here. So when you guys are assessing your patients, if you see something you don't recognize, this website's a great resource for you guys to go to and try to look at these different skin conditions. And like I said, they have a whole bunch down here at the bottom. So I linked it in there for you guys so you can look at it if you need to in the future. All right. Oh no, it went back to the beginning. There we go. The next link on here I'm not going to go to because this is an hour-long video, and I don't want to watch an hour-long video with you guys today. But I linked it because it is free for you guys, and they literally made it for nursing students that are going to go into practice soon. And it's this huge, long, in-depth explanation of how to assess for pressure injuries, what to do when you find them, who to call, what you can do at the bedside without an order from a physician. It's from one of the leading experts in skin from up in the higher levels of the Wound Ostomy Incontinence Society that I'm a member of. It's an amazing resource for you guys. It's got images. So you, like, if you're not sure, is this a stage 1 or a 2 or a 3? Like, they have images in this video that you can just pull up and look at it to compare. So I put that out there for you guys just as a resource. And again, it's free. So if you need some sleepy time video watching, go to sleep. So now we're going to move on to our pre-op nursing care. Pre-op nursing, preoperative nursing, literally starts when they come to the pre-op unit. I mean, actually, in all reality, pre-op nursing starts the day that you have the discussion with the doctor that you're going to have surgery. But in reference to this class, it's when they show up to the pre-op unit. So it's the day of surgery, they show up, you're there to get them ready to go back to the OR. It's considered pre-op until they go to the OR. So they're with you, get their ID, you make sure they've got all their things they need, you send them on their way. As the nurse, there are 3 main responsibilities. You're going to do a pre-op assessment. You're going to do a head to toe. You're going to check them over. You're going to make sure. You're going to check for pressure injuries before they go sit in the OR for 8 hours. You're going to do that pre-op assessment. You're going to do patient teaching. So hopefully they've previously gotten teaching on their whatever they're going to have done and what their post-op period is going to look like, but you're going to reiterate it today. So they've already learned in the clinic. They're going to learn again when they meet you. And then your job is to ensure that that informed consent has been signed, that it's signed, it's physically in the chart, we have it, we know they've signed it. That pre-op assessment, you're going to get a good health history. You're going to check with them about everything they've ever had. My students yesterday at clinical, I had them print out chart summaries for us because I didn't want to spend all the time on the computer. And as they know, some patients have 3 pages of health history because they're 93 years old and they've lived a life. So you're going to ask your patient about all of their health history, though. You're going to find out everything they've ever had, including surgical history. So what all surgeries have you had? Sometimes they're even going to tell you how many teeth they've had pulled. So they're going to say, I got my wisdom teeth out when I was 19. I mean, they're going to tell you everything they've had. You want to ask about allergies and not just to medications. Are you allergic to latex? Are you allergic to other things so that we don't use them on you when you're unconscious and you can't tell me that you're allergic to them? You want to ask about current medications and supplements. And remember, we talked about that before. You always want to ask about supplements because they don't always consider that a medication if you ask them what their medication history is. So you want to know anything that they're taking that comes out of a pill bottle of any kind. You want to know about any spiritual or cultural beliefs. You know, if your client is Jehovah's Witness and is not going to be okay with getting blood products, you need to know this before we give them blood products when they're unconscious. They may have other beliefs that we need to know about before we get into the OR. You want to do that thorough physical head to toe assessment. You want to know everything about them before they go in. And then if they haven't previously had it done, you want to make sure that they have any diagnostic or lab testing. So sometimes before a major surgery, they will ask for your patient to get a chest x-ray, an EKG, and then get some blood drawn. You want to make sure that it was already done or that it gets done today before we go back to the OR. A lot of times those are ordered by anesthesia because they're the ones monitoring that. But either way, it's your responsibility to make sure that it got done before they go back to the OR. For patient teaching, it's going to look a little different than when you do the initial teaching with them in the clinic and you're telling them like the whole world for the next 6 months. A big part of what it is you're going to tell them how the day is going to go. So you're going to tell them, when we're done here, I'm going to hand you off to this other nurse. She's going to take you to the OR. Anesthesia will take care of you there. You'll meet your team. Afterwards, you're going to go to PACU. And then, you're either going to go home or you're going to go to the floor. But you're going to tell them the order of events for the day. Before they come in, you're always going to let them know what time to arrive. So if anyone's had surgery or taken a loved one for surgery, they always call a few days before and say, be here at 5 a.m. for your 7:30 surgery. But you want to make sure they know that. You want to make sure before they get there, they know where to check in. It's already scary enough to know you're going to go be put to sleep and someone's going to cut on your body. Let's not also add the extra anxiety of, I don't know where to go. Make sure they know where to go, what they can bring, what they should leave at home, who they can bring, how many visitors can they have? We don't want 10 people in pre-op and in PACU. So how many people can they bring? And then how long they can expect to be in the hospital? So is this outpatient? Are they going to go home the same day? Or can they expect to be here for a few days until they recover? When you're making like a pre-op phone call to do teaching, you want to let them know what their MPO status is. What do you think I mean by MPO status? But for how long? So some surgeries, they want you MPO for a day or two. Some it's just midnight. Make sure they know. Maybe it's not surgery. Maybe it's a colonoscopy. They have to do clear liquid diet for so many days beforehand, and then they have to take bowel prep. So you want to make sure they know when they should be MPO and what they should do before that. Skin prep. Oftentimes they need to do a skin prep before they come in. When I had my hysterectomy, I had to do a medicated bath the night before, put on clean pajamas, put clean sheets on my bed. In the morning, I had to get up and use a medicated shower again. I could not use any regular soap or body products. I wasn't allowed to put deodorant on. When I got to the hospital, I had to do a skin wipe down again with a medicated bath. So make sure if they need to do all that you let them know, because nothing's worse than showing up for surgery and because you didn't do your medicated shower, now you can't have it. So you want to make sure if there's any type of skin prep that they know far enough in advance that they can complete that. Make sure they know what medications they can and cannot take. You're going to know that when you make the phone call. You're going to have a list from the anesthesiologist saying what they can have. But there are some medicines they want your client to have. If they take something to control their heart rate or their blood pressure, they're probably going to want them to take that because they don't want you to come in hypertensive and all crazy. They want you to be stable before they start doing things to you. But maybe they don't want you to take your blood thinner for 7 to 14 days. So you're going to make sure they know when to stop anything and what to keep taking. If they are smoking or drinking alcohol on a regular basis, they're probably going to want them to stop. So you're going to try to work with them on tobacco and alcohol cessation before their surgery. The reason for that is both of those things affect your ability to heal. And so they want to make sure that you don't do those things when you go home. You want to let them know what their post-op expectations can look like. So what should they expect immediately following surgery? What's that pain going to look like? What's that nausea going to feel like? What's their mobility status going to be? Make sure they kind of know what to expect. You want to make sure they know how to rate their pain and what we're going to do to control it. If you know what the post-op pain regimen is going to be, tell them, let them know. Like this is what we're going to do to help you be comfortable after surgery. You want to start stressing the importance of the coughing, the deep breathing, and the incentive spirometer. Oftentimes you want them to demonstrate they can use that incentive spirometer before they go back. Do it now while you don't hurt and show me you know how to use it. So that way when you're in pain and you're telling me no, I at least know you know how to. I just have to convince you to do it now. And then make sure they know what their activity level is following surgery. Maybe they're allowed to get up and move around as they please, but they can't lift anything. again, after my hysterectomy, I wasn't allowed to lift more than a gallon of milk for like 6 months, which is really hard to work as a nurse, by the way. But I wasn't supposed to lift because they didn't want me to undo everything they had done internally on me. Make sure your patient knows what they can and cannot do before they leave you. For informed consent, I put a whole lot of words in here because I just want to make sure that it's very clear what your job is. So it is that provider's responsibility to make sure they understand what they're going to have done, what the other alternatives are. Can they do medication or radiation or chemo instead of surgery? Like, what are all my alternatives to this specific surgery? What are the risks and benefits of this planned procedure and all the other options? It is their job to explain that. If the client can't make their own decisions because they're a child or they're an older person, they're explaining this to the loved one. They're explaining this to the person who's signing their consent. But it is that physician or that provider's job to make sure they understand what is happening. Again, a designated decision maker, that can be a legal guardian, that can be a healthcare proxy or a healthcare surrogate, but it's somebody who's legally allowed to make decisions. So for me, that would be my husband if I can't make my own decisions. It could be a parent, it could be whoever, but they need to know who your decision maker is. As the nurse, your primary responsibility is to witness the paper being signed and to make sure that they've actually signed it. So sometimes the doctor goes in, has a whole beautiful conversation, patient's on board, patient signs, and doc walks out and never signs the paper. So you are responsible to make sure everybody who needs to sign it has physically signed it in the presence of you as the witness or someone else as a witness. You are allowed to clarify information. You just can't give new information. So maybe the doctor explained it in big, broad medical terms. You can explain it in plain language to your patient. You just can't give them new information. So if maybe the doctor forgot to tell them a different alternative, you can't tell them about that alternative until the doctor does. So sometimes what will happen is you're in the room when they're doing the conversation and they'll forget to mention an alternative. You can remind them politely in the moment, like, hey, this is also another thing. And then they have to tell them because you've brought it up in the doctor's presence. But again, you can clarify because sometimes nurses are much better at explaining things in plain language than doctors are. So you can clarify. Another thing you want to do before the conversation even starts is to determine if the client is legally able to provide consent. So maybe they're of age, maybe on the surface they seem like they're learn-oriented, but once you've talked to them for 5 or 10 minutes, you realize that they're horrifically confused. You need to kind of determine that. Are they legally able to make this decision? Because you can't have somebody who can't understand signing a consent for something that they don't really know what's going on. So you have to kind of have that conversation. The one that happens often is maybe they're on chronic pain meds at home. You can't sign a consent form with pain medication in your system because you're not really sober at that point. So you need to make sure that when they're signing the consent, they haven't had any pain medicine or anything like that that can make them unable to make a good decision. And then if they're under 18 and they're an emancipated minor, you have to make sure you have that paperwork proving that they're allowed to make their own decision at that point. You can't just go by their word. For post-op nursing care, obviously it's after surgery. So primarily it's going to be PACU, but sometimes if it's a crazy enough surgery and they go directly to ICU, it will also be that ICU setting. PACU and ICU nurses are both trained in ACLS, which is Advanced Cardiac Life Support. I am not trained in that. I am BLS only. You don't want me in an ACLS situation because I don't know what's happening. But they're trained in that because after surgery, patients can be their vitals can be very volatile. They can be very fragile. So those nurses are trained in ACLS for a reason. Initially post-op, they're going to be doing frequent assessments depending on what the surgery is. You know, if it's a ortho surgery, they're going to be assessing whatever limb we worked on. If it's an abdominal surgery, obviously we're assessing that. But whatever we worked on, they're going to be doing frequent assessments. They're going to be giving those meds. So if you are nauseated, they're going to give you nausea medicine. If you're having pain, they're going to give that. Maybe you wake up and you're having an anxiety attack. They're going to give you medicines to combat whatever you're having. They're going to start your post-op pain regimen. They're going to give whatever we've got ordered for pain in PACU or the ICU. And then they're going to help prevent complications. So A lot of times right after surgery, we're still numb and we try to move like how we shouldn't. So they're going to help prevent you from jumping up out of bed and falling or pulling out a drain or busting open your incision so that you're preventing any complications that might happen. The biggest priority is maintaining a patent airway. What do I mean when I say patent airway? Open, right?
Mm-hmm.
So if you've had major surgery, they've put a tube down your throat to let you breathe. When you go to PACU, they're going to yank it out. Just going to pull it out. It can close back up. So a big part of PACU specifically is make sure their throat stays open. Recognize that it's closing up and call someone quickly to come fix it.
Mm-hmm.
In the ICU, they may still stay intubated, so it's not as big of a deal. They may be intubated and on a vent, but that PACU nurse, most of the time they're extubated by the time they get in there. And then the other thing is monitoring the cardiovascular status. So our bodies don't like being put to sleep. They don't like being cut into. Your heart and your lungs can get very angry about it. So you want to have them on a monitor while they're in PACU or when they're in the ICU, just to make sure that their heart rate, their blood pressure, everything is doing like it should, like it was before surgery. So your key tasks before discharge from PACU, you want to inspect any incision sites for infection. Now, obviously, if it's just PACU, they shouldn't have an infection already, but you still want to monitor those incision sites, make sure they look clean, dry, they have a nice dressing on them if they need one. You want to promote wound healing through an appropriate dressing. So know what the doctor wants you to put on it. Do they want it left open to air? Do they want it covered with something? Do they want an ointment on it? What do they want on it? And make sure it's on there. Encourage mobility to prevent pressure ulcers. So I was telling someone I met with this morning, people who've had a hip or a knee replaced, we want them up walking within 4 hours of surgery. Like, we're not sitting around, we're getting up, we're walking, we're moving. I have transplant patients at University Hospital that have had a liver, a kidney, and a pancreas transplanted, that they have them walking while intubated and on the vent around their bed within 6 hours of surgery. We have heart transplant patients that they have RT, PT, OT, the nurse, the doctor walking them down the hallway, pushing a mobile vent. So we get you up and you walk whether you want to or not after surgery.
Mm-hmm.
Not just to prevent pressure ulcers, it's good for your lungs too.
Mm-hmm.
And then you want to educate someone on the home care for those wounds. So if they are still too loopy, you're going to do whoever's taking care of them at home. But you want to at least cover, like, you have this incision, this is what we're going to have you do for it and how often and when you're going to come back to the clinic. And that's it. So we are going to take a short